Hello guys, this is part 2 of the stepladder model for the treatment of chronic asthma. But before I go on, I'd like to make clear and explain some terms that I'll be using. The first is inhaled corticosteroid formoterol combination, which is also known as ICS formoterol. This has a formoterol component that acts to open up the airway rapidly and can leave the airway open for a long duration. The other component, the inhaled corticosteroid, would function to control the inflammation. Now this would make the ICS formoterol both a reliever and a controller in its duties. The other term is the inhaled corticosteroid long-acting beta-2 agonist combination, which is also known as an ICS LABA. The LABA component would function to open up the airway and leave it open for a long duration of action, while the inhaled corticosteroid would also perform the role of controlling the inflammation. The next is short-acting beta-2 agonist, SABA. This would open up the airway rapidly and would generally be used as a reliever. The long-acting beta-2 agonist is the next. This would open up the airway and leave it open for a long duration. However, not rapidly. And this may be used in a component for controlling asthma. The long-acting muscarinic antagonist would also open up the airway and leave it open for a long duration, but generally would be used as an add-on therapy. Now, for the stepladder model, patients are generally placed in steps 1 to 5, depending on the frequency of breakthrough symptoms that occur during the day and at nights, and also depending on their lung function. Each of these steps would have their relievers and their controllers. Patients who are in steps 1 and 2 would require as needed inhaled corticosteroid treatment, while patients in steps 3 and above would require a maintenance or regular daily inhaled corticosteroid containing treatment. For patients in step 1, when the reliever is an ICS formoterol, this will usually double as the controller. But when the reliever is a SABA, the controller is an ICS that is taken with the SABA or shortly after it. For patients in step 2, when the reliever is an ICS formoterol combination, this would also double as the controller. But when the reliever is a SABA, the controller is a low-dose ICS alone. For patients in step 3, when the reliever is an ICS formoterol, the controller is a low-dose maintenance ICS formoterol. But when the reliever is a SABA, the controller is a low-dose regular ICS LABA. For patients in step 4, when the reliever is an ICS formoterol, the controller is a medium-dose maintenance ICS formoterol. But when the reliever is a SABA, the controller is a medium-dose regular ICS LABA. Patients who are in step 5 are patients who generally are on maximum doses of these medications, yet still have poor control of their symptoms. This category of patients are best referred to the specialist for re-evaluation of their type of asthma. They can also have add-on therapies to their maximum doses that they are on. These add-on therapies would include the LAMA and biologics. It is important to schedule a follow-up for these patients 2 to 3 monthly or as frequently as is necessary. During follow-up, the patients are assessed for their asthma, risk factors, comorbidities, their symptom level, inhaler techniques, and their goals or preferences. Adjustments will be made in their treatments or whatever is found during assessment. And these patients can be stepped up or down the treatment ladder depending on their symptoms. Thanks for watching, and please don't forget to subscribe. For more videos, you can like and share and leave a comment.